Great. So, Assalamu alaikum, everyone. My name is Mariam Alissa. I'm a third year medical student. Inshallah, today I'll be giving you a lecture about gastric response to meals. It is a bit of a heavy lecture, but inshallah, like all is gonna go good. This is my contact info. If you want to ask me absolutely anything, I'm more than happy to help. Let's start. Okay, so let's start with the table of content. First of all, we're going to be talking about the basic anatomy of the stomach, just a brief recap. And then we're going to be discussing the phases of gastric secretions, which is kind of the main topic of today's lecture. And then we're going to mention some clinical aspects, nothing too deep, but it's really fun. And then we're going to move on to the second heavy section, which is gastric motility. And lastly, we're going to be ending it with vomiting reflex. There's a couple of practice questions at the end, so yeah. Now let's start. Let's start with a quick anatomy recap. So this is the stomach, all right? And we know the stomach is made up from different parts, okay? We divide it into different regions. The first one is the fundus, okay? This is the very upper portion. Then you have the body, which constitutes about like 70% of the stomach. Then you have the antrum. And lastly, you have the pylorus. The pylorus is the very lower end of the stomach. And I like to think of it like a gate, a gate that connects the stomach with the intestine or the duodenum to be specific. Now, since this is a physiology lecture, we need to understand the important cells that reside in the stomach lining. So the first one is going to be the parietal cell. Okay, the parietal cell is located in the body of the stomach, and it mainly secretes the hydrochloric acid or HCl as well as the intrinsic factor. Then we also have the chief cell or the peptic cell, and the parietal and peptic cell, they go hand by hand. This is why they're both located in the body. Right. So what does the peptic cell do? It secretes pepsinogen as well as gastric lipase. And we're gonna get to know all these enzymes later, but for now, just know the names. Then we have the G cells. The G cell is located in the antrum. Okay, so in the lower end. And this is responsible to secrete the hormone gastrin from GG. So gastrin, G cell. And then we have the mucus next cell. The mucus one is also found in the antrum, and it secretes mucus and bicarbonates, again from the name. So if you want to go into the sorry, yeah, into each one of them separately. Let's start with the peptic or chief cell. As we said, what does it release? It releases pepsinogen. Now, what is really important for you guys to know, and the pepsinogen is an inactive form. Okay, so when pepsinogen is released, it basically is not doing anything. Until it's activated, it's gonna implement its effect, right? So who releases pepsinogen? The chief cells. Now, pepsinogen, who's going to activate it? The HCl that is produced by the parietal cell. So this is why I said they go hand by hand. Unless the HCl is being produced by the parietal cells, the pepsinogen is not going to be activated. Okay, or it's not going to do its job. Now, once it's activated, it turns into pepsin. Okay, you remove the ogen, it becomes pepsin. Now, what is pepsin used for? It's used for protein digestion. So meat, eggs, chicken, anything really that is like high in protein, it will require pepsin to break it down. Okay, and again, where are the chief cells located? In the body of the stomach. Now, for the parietal one, as you guys know, and it secretes HCl, hydrochloric acid, and this is the main factor that makes the gastric juice so acidic, as in the pH of 0.8, which is very, very, very low. All right. Also secretes the intrinsic factor. Now, what is the intrinsic factor? You don't really have to know it in detail. It's just like a factor that goes and binds with the vitamin B12, right? And takes it all the way up to the ileum, or like a part of the small intestine, the lower end of the small intestine, and it helps in absorption. You don't have to know it in details in this lecture at least, but just know it releases HCl and intrinsic factor. And again, it's found in the body. Then we move on to the mucus neck cells, and the mucus neck cells, from the name, they release the mucus and bicarbonate. And what is the main job of mucus and bicarbonate in general is to make something alkaline, which is the exact opposite of HCl. So it makes so much sense to have it at the antrum, or basically the lower end of the stomach, because this is, as we said, the gate between the stomach and the duodenum. So and the gastric or the stomach has a different lining when compared to the duodenum. And this is why the stomach can withstand very acidic environments compared to the duodenum, which really cannot. So this is why the mucus neck cells are found in high concentrations towards the end of the stomach, or specifically the antrum and the pylorus, just for the sake to try to alkalize whatever food or chyme is moving on from the stomach to the duodenum, okay? Right. Then you have other glands, pyloric glands like D and G cells, and we're gonna dive into these later, specifically what they do and so on. However, in general, they do release gastrin. As we said, G cells do release gastrin and mucus. Okay? All right. Now, for the main part, which is the gastric secretion phases, we have three phases, right? The first one is the cephalic one. We're going from up to down. Cephalic is from the word head, right? So we're going up. It constitutes, yeah, okay, cephalic, then the gastric, then the intestinal, right? Now, what are these percentages? These percentages resemble how much does each phase like contribute to the gastric secretions or gastric juices, right? So you can see in the cephalic only is 30%, which is good. And then the gastric is 60, and this is like the main boss in here, right? The gastric one is the one that produces the most amount of gastric juices. And lastly, you have the intestinal, which is only about 10%, because makes sense. The intestine, why would you need a lot of gastric juices, right? Right. So now we're going to move on to each phase individually and what happens in them. All right. So this is the cephalic phase. Now, we're going to start with the stimulus, right? And then the mechanism. So what initiates the cephalic phase? If you know when you go into the kitchen and you see food, or you smell your mom cooking something or whatever, and your mouth starts to water, and you're like, your stomach starts to grumble and everything, yeah, this is the initiatory phase of the cephalic one. So if you my bad. Okay. So if you Okay, so if you swallow food, or if you smell food, or if you see it, or if you think about it, this is considered to be a stimulus for the cephalic phase. Your mouth starts to water, okay? Now, what exactly happens is that all of these factors are going to stimulate a very big nerve found in our body, which is known as the vagus nerve, right? This vagus nerve, you're going to hear it being mentioned over and over again because it is such a huge one. And I want you to think of it as a connection between the brain and the stomach. Okay? So you had all these stimulus, right? From tasting to smelling to chewing to everything. It stimulated the vagus nerve. And this stimulated what? This vagus nerve, what did it do? It stimulated two things. It stimulated the parietal cells to release HCl, okay? And it also stimulated the gastrin release via the GRP, or gastrin releasing peptide, which is basically the same thing. Yani it's activating the G cells, okay? So now we have parietal cells that are activated, and gastrin also that's being released. So HCl and gastrin are starting to be released only in 30%, okay? Not in a huge amount, only in 30. طيب, what is the point of this? Like, we still didn't eat anything technically. Why are we producing all of these already? It's simply because we want the body is trying to basically prepare itself to digest food. Imagine, I know you just suddenly eat food and you overwhelm your body and it has zero acid in it, and okay, not zero, but like very little levels of it, that doesn't make sense, So to prepare itself, this is why the vagus nerve goes and activates these two. Now, you can see here I wrote ACH, which is basically acetylcholine. And acetylcholine, if you guys know by now, it's a neurotransmitter, right? So the vagus nerve basically released acetylcholine to go and stimulate the gastrin release. Okay? تمام. Let's say we cut off this vagus nerve. طيب, it's like non-functional, or like it underwent a vagotomy, which basically means, you have just a non-functioning vagus nerve. What will this result in? This will result in basically this phase not occurring, or all the other phases as well. Because as we said, this vagus nerve is a very important bridge, okay, between the brain, the higher centers, as well as the stomach. So this is not going to work. طيب. We also said that this vagus nerve releases acetylcholine, right? And acetylcholine goes and helps in the release of gastrin. طيب. There are some drugs, all right? Like, I'm pretty sure you guys have not went through this, but like there's a drug known as atropine, okay? Atropine is a drug that goes and inhibits acetylcholine. Okay, it inhibits this part here, right? So if it inhibits this part, this result is not going to happen. In other words, gastrin is not going to be released, right? Like, will this affect the parietal cell activation? No, right? Because like the acetylcholine is only in this part, it's not in this part, and I'm not affecting the vagus nerve, I'm just affecting this part. Therefore, gastrin is going to be decreased. But gastrin is really important, right? Because it's the major constituents of the, of the HCl and everything. So this is pretty major. This is a pretty major effect. But yeah, that's about it. Now we move on to the gastric phase. Okay, right. Okay, here. So now you prepared yourself and the stomach is like khalas, like it has like about 30% of the gastric secretions and it's like it's getting ready. Now you ate the food. The food is slowly going down your esophagus to the stomach. What is going to happen to the stomach? Actually, what is the stomach made of? The stomach is basically muscles, right? And it's usually shrunken when it has no food in it. طيب? So when the food starts to enter, this is gonna distend the stomach. It's gonna start to expand. All right. And in addition to amino acids and peptides in the stomach, and whenever the stomach senses that there's amino acids and peptides in it, this is going to stimulate the vagus nerve again. Okay. However, this time it's on a way bigger scale, and it's known as the vasovagal reflex. Right, so what is the vasovagal reflex? Here you can see when the stomach, the food start going in it and amino acids and so on, it distended it and this sent a signal up to the brain via the vagus nerve. Okay, this is the vagus nerve, okay? The brain integrated that and they were like, okay, so now we have to, okay, we're now in the gastric phase and we have to take care of it and start digesting our food properly. So it sent signals back again to the stomach. And this time, what is the order from the brain? The order is to stimulate the G cells to secrete gastrin and the ECL cells to release histamine. Okay? This E cell, I know I haven't mentioned it like so far, but it's like very dismissive and the only thing you need to know about it and know it secretes histamine. طيب هلا we have gastrin and we have histamine. Why do we need these two? What is the point of it? We needed HCl. Why are we releasing these things? These two are going to go and activate the parietal cell to release the HCl. So all of this cycle is simply because the vagus nerve cannot directly communicate with the parietal cell. It cannot have this like direct like line of communication, because the body is so complex, it never does anything simply. So they needed to stimulate the G cells and the ECL cells first to help in the production of HCl, because now we have food in our stomach. We want to break it down. All right. So this is basically what I said in words. The stimulus, again, is distension of the stomach, amino acids, and so on. It activated the vasovagal reflex, and this helped in the release of GRP for the G cells, the ECL for histamine, and acetylcholine as well. Okay, and all of this to help increase the HCl production because we want the secretions to be up to 60%. Okay, because now we have food in our body and we want to break it down. طيب. If you notice, I mentioned acetylcholine. Okay, now again, this is for refreshment again. This is the vagus nerve. The vagus nerve, once it's activated, it's going to release a neurotransmitter, which is acetylcholine. This is supposed to be here, I'm sorry. But anyways, the neurotransmitter acetylcholine. Now, acetylcholine, because we mentioned it so much, it has so many functions. Okay, this acetylcholine, right, was released in the cephalic phase and also in the gastric phase. In the gastric phase, it's going to stimulate the G cell, the ECL cells, and the parietal cell. So basically everything. It's going to go directly to stimulate the parietal cell for HCl. It's going to directly stimulate the ECL cells for histamine. And last, it's going to activate the G cells to release gastrin. And gastrin and ECL both go and stimulate the parietal cell. So this, I know, is a bit confusing. This is why I took this diagram, which is really nice from your slides. So here you can see, and now these are the stimulus. We talked about them. Then you can see here the vasovagal reflex releasing acetylcholine. This local ENS reflexes, you don't really have to know what are these. You just need to know another nerves. Like they're just nerves, just like the vasovagal. Anyway, so both of them really going to release acetylcholine. And acetylcholine, again, it's going to go stimulate gastrin, ECL to release histamine, and directly the parietal cell. Okay? Now, Again, the gastrin and the ECL cells themselves are also activated and they go because due to the vasovagal and they go and also activate the parietal cell to release HCl. So you can see now there's a lot of things that are trying to stimulate the parietal cells. Why? Because we want 60% of the gastric juices. This is the heaviest part of the gastric cycle, you know? So this is why there's so many things that are playing a lot of factors to the parietal cell. Tamam? I hope all is clear. Um, Okay. Now we know, okay, we keep saying HCl, HCl, HCl. طيب, how is HCl going to form in the first place? And if you want to take a closer look at the parietal cell, how is it going to make it? From what is it going to make it? You know, there's four main steps. The first thing is that there is an enzyme known as carbonic anhydrase. All right, you're going to hear it so many times. This carbonic anhydrase, it basically takes carbon dioxide as well as water and it forms carbonic acid or H2CO3, right? This carbonic acid, we don't want it. Tamam? I don't know why did we make it in the first place, but we don't want it. So we want to dissociate it. We want to break it down. So what are we going to break it down to? We're going to break it down to hydrogen ion as well as a bicarbonate ion. Tamam? Tamam. هلا, you can guess from where this is going. This hydrogen ion, we don't want it to stay in the parietal cell. We want it to get out. We want it to get to the stomach lumen. Tamam? Yeah, because we want to break down the food. And where is the food? In the lumen, in the mucosa, right? Tamam. هلا, this hydrogen ion, it cannot just leave. Tamam? There's an active channel or active transport channel that is communicating with the outside. And I'm pretty sure you took this in foundation and all throughout the last term. However, for a active transport channel to work, you need to let out something and take in something. So what is the thing that we're going to kick out? The hydrogen ion. And what is the thing that we're going to take in? The potassium. The potassium is not really important, like it's dismissible for the, considering gastric, it's obviously not like it's normal physiologically. It has other um like functions, but for gastric juices, not really. Okay, so now we have the hydrogen out and potassium in. And what is this channel called? This is known as the hydrogen potassium ATPase pump or the proton pump. Tamam? And this is probably the most important channel out there. There's so many drugs that act on it. There's so many diseases that affect it. So yeah, right. So yeah, so that's it, okay? So we have hydrogen out and potassium in. Now, what do we want after this?
I
We
have
want,
a question.
yeah, go ahead.
What is the thing that we produced at first and that we don't need?
You mean here in this news?
Yeah, is it carbonic anhydrase?
Okay, so carbonic anhydrase is an enzyme, okay? And it made carbonic acid, which is H2CO3, this one. This one is the thing that we don't need. Okay, like it has no process or no affiliated process in the gastric secretions. So we're gonna break down this H2CO3 into hydrogen and bicarbonate. Did you get it?
Okay, thank you.
Of course. So this H2CO3, we don't need it. This is why I break it down further. ماشي? Okay. Right, so now that we have hydrogen ion out, we want the other half of the HCl, which is Cl. We want the chloride. Now, where's chloride coming from? You can clearly see, no, it's not in the cell. We don't store chloride in the cell. So we need to take it from the blood. Okay, now how are we going to take it? Via another channel. And this channel is known as the chloride bicarbonate exchanger. So here you can see the chloride is going to come in the cell and bicarbonate that we took from the carbonic acid is going to be kicked out to the blood. Right? Because obviously you take something, you need to give out something. So we took ClN and Cl via passive diffusion is going to leave the other side of the cell. Okay, and it's going to join the hydrogen ion to form HCl. Okay, so chloride does a little bit of a journey. It comes from the blood and then it gets exchanged with bicarbonate. Then it goes via chloride channels and lastly it joins with hydrogen outside the lumen. And yeah, basically. تمام? All right. Now that we have HCl forming outside in the lumen, this HCl, خلاص, it's going to do its job. It's going to break down stuff. It's going to go and stimulate the pepsinogen. It's going to lower down the pH of gastric juices to 1 or 2. Okay, it's that low. It even reaches 0.8 sometimes. I mean, yeah, it does reach, not sometimes. تمام؟ طيب. There's a certain phenomena you need to know, which is known as the alkaline tide. This alkaline tide is not really high yield, يعني, but what you need to know and know what is it caused by. Now, when we took the chloride in, we said إنه we pushed the bicarbonate into the blood. طيب هلا this bicarbonate, if you guys know, it is an alkaline substance. It alkalizes stuff, just like how HCl is acidifying the lumen of the stomach and the fluids in there. The bicarbonate alkalinizes stuff, you know? So they raise the pH instead of lowering it like the acid. So when it raises the pH of the blood, even for a moment, this is known as the alkaline tide. The way they can ask you about this is they're going to be like, okay, what causes, like, which of the following causes the alkaline tide phenomena? You will say bicarbonate being pushed to the blood in exchange for chloride. All right, that's it really. And then, lastly, hello. Guys, like, okay, so we went through the cephalic phase, we went through the gastric phase, everything is stimulated, there's HCl being produced, gastrin is being released, you know, everything is going well. Hello, will the body keep on producing HCl till forever? Till like all throughout the process of eating, do you think HCl is being produced and produced and produced and produced? Obviously not. The body will literally burst from HCl. We need only like about 60%. And the stomach, صح, it is accompanied and it can accommodate acidic environments, however, like too much. So there is obviously an opposite regulatory pathway from the body itself, okay? And this is basically, and the feedback basically is, and no, whenever the pH in the stomach reaches so low, as in 0.81, you know, which is the targeted value, this is going to inhibit the gastrin secretion from the G cells, okay? It doesn't inhibit the parietal cells. I told you there's no direct communication with the parietal cell. It's always via something. And that something is gastrin. So we're gonna inhibit gastrin from the G cells to inhibit the HCl production. Because if you remember, as we said, gastrin is being there and it's going to stimulate the parietal cells to release HCl. So if we inhibit gastrin from the first place, خلاص, HCl is not being stimulated or is not being produced in large amounts at least. Obviously, a very small amount will be produced because there's still histamine from ECL cells, there's still acetylcholine, come on. However, these form only like little values or little percentages of the HCl. The main contributing factor is the gastrin. Mashi? So this is known as the feedback regulation, and this is a very normal physiological process done by the body. Perfect. Moving on. This is just like a summary thing. So here you can see this is again the gastric phase. This is the vagus nerve releasing acetylcholine. Acetylcholine goes and binds to the M3 receptor. You don't have to know the names of these receptors. Just for the sake of completion, I'm gonna say them though. So this is the M3 receptor or the mesenchymic receptor. And this, what does it do? It goes and stimulates the proton, the proton pump to release hydrogen ions. Then you have the G cells. The G cells release gastrin. Gastrin binds into the CCK receptor. Again, you don't have to know the name. Then that goes and stimulates the proton pump to release hydrogen. Then you have the ECL cells. The ECL cells release histamine. Histamine is going to go bind to H2 receptors, and then it's going to go and stimulate the proton pump and so on. طيب هلا we did mention atropine in the cephalic phase. Atropine again is a drug that acts against this receptor. تمام? So because we cut this off, acetylcholine cannot go and stimulate the hydrogen potassium ATPase's channel. But does that mean that gastrin and ECL are affected? No. These are working just as fine. So yeah. Now we'll go on to another inhibitory pathway. We did talk about like the normal feedback one. However, there's other mechanisms the body follows to inhibit overproduction of HCl. And the first one would be somatostatin. Somatostatin here is a hormone that's released by the D cells. Okay, and they go and bind to a certain receptor called GI. G is the name of the receptor. It's called G receptor, and there's many subtypes of it. There's 3 subtypes, I think. However, the one that it's going to bind to is the GI. I stands for inhibition. Okay, so again, somatostatin is released by D cells, and then it's going to bind to the GI receptor, and then this GI is going to decrease the levels of CAMP. And CAMP is the main fuel for any channel. تمام? So will the ATPase work if we inhibit CAMP? No, it's not gonna work. So if it doesn't work, معناتها, or that means that the hydrogen ions are not being produced. Okay? All right. Now for prostaglandins, they're also normal, like they're also produced by the body endogenously. And prostaglandins follow the exact same pathway somatostatins do. Prostaglandins are gonna go and they're gonna bind to the GI protein, protein coupled receptor, and then it's gonna reduce also the CAMP levels to decrease the hydrogen secretion. All right. Right. So these are the normal three pathways, the somatostatin prostaglandins, as well as the normal feedback regulation system. Now, we as physicians can also interfere in this. We can give certain drugs to help reduce the acid production. Now, in what's like for the sake of your understanding, what scenarios do we wanna like decrease acid production? Does anyone know? Like throw a random guess. Um, It's okay. Basically, in situations when, for example, let's say the person has overproduction of HCl, or in situations where the patient has, let's say, like an ulcer, if you know what's an ulcer or an erosion in the stomach lining, or in other words, the stomach lining is like breaking down. So if you produce too much HCl, it can actually leak and damage other organs. And we know HCl is only accommodated with the stomach. Other organs in your body are not accommodated to acidic pHs. So that is going to damage other organs and can cause so much pain. So in this case, we as physicians, we give them certain drugs, all right? The main drug that we're going to give, they're known as proton pump inhibitors or PPIs, and they go and inhibit this channel here. This channel, as you can see, everything is related to it because it's the most important one. This is why we give a drug to inhibit it. Do you need to know the name of the drug? No, you don't. I'm pretty sure you don't. Omeprazole, though, for the sake of understanding. But just know, and we give them PPIs, okay? And these PPIs, they go and inhibit this channel. And this is going to immensely reduce the acid production. Then there's another one which is H2 receptor blockers, and these will inhibit this one here. And this will also reduce the acid secretion, right? But not as a huge level, like as compared to the PPIs. PPIs is the main management technique in here. طيب هلا we talked about how is HCl produced, what stimulates HCl, what cells, and so on. We now like we'll go over the functions that you guys already guessed by now of the HCl. HCl creates an acidic medium, as we said, and it helps in digesting proteins and many like food substances and so on. And it also does have an antibacterial action, and it helps in secreting and regulating the motor and security function of the GI system. And this is not really important. But the most important function is the pepsinogen activation. We said pepsinogen is produced by the chief cells or the peptide cells, and it's inactive form. So who's going to go to activate it? The hydrochloric acid. So the hydrochloric acid is going to go activate pepsinogen and convert it into pepsin. And this pepsin is going to go and break down proteins and produce the whole like chyme and all these things. And pepsin only now, okay, why do we want like what is the main what's the main like rationale behind pepsin only working with HCl? Simply because pepsin like pepsinogen is not broken down into pepsin unless it's a very, very acidic environment. This is how it's created and this is how it's produced. It needs a very acidic medium, and the only one that provides acidic medium is the HCl. This is why it goes hand in hand. Now, we finished with the gastric phase. I hope all is clear. And yeah, now we're gonna move on to the intestinal phase. The intestinal phase is basically the food being transferred from the stomach into the duodenum or the intestine in general. And the intestine's main job is to absorb nutrients rather than digest. The digestion is the main function of the stomach, and the intestine is there to mainly absorb, right? So this right here is known as the chyme, tamam? Chyme is basically the end product of the gastric phase. Chyme is going to be transferred from the stomach into the duodenum. And this is the marking of, this marks the beginning of the intestinal phase, all right? طيب هلا this is how you stimulate it via the entry of chyme. How can you inhibit it? And this can come as an MCQ, by the way. For to inhibit the intestinal phase, one obvious thing would be high acidity. Because as I said, the only organ in the system that can withstand this highly acidic environment is the stomach. So the duodenum cannot do it. So the moment that the duodenum senses and know there's very high acidity, this is when the intestinal phase is inhibited. Okay? And what is going to happen as a response to that? Obviously, it cannot put the food back. Yani back to the stomach, obviously, it can't do that. So, what is going to happen? The D cells are going to be stimulated to release somatostatin. And as we said, somatostatin, what does it do? It inhibits gastrin. And what does gastrin do? Stimulate HCl. So, if we inhibit gastrin, خلاص, there's no more HCl. And this is what we want. We want the chyme to be alkaline. Right. There's also other hormones that are released like CCK, secretin, and GIP. These, I'm pretty sure you're going to be exposed to them later, like in other lectures where they discuss the intestinal motility and like other stuff. But for now, just know their names in general. But the most important one is somatostatin for gastric.
Um, can you repeat what the D cells will do?
The D cells.
Yeah.
Okay. The D cells, their main job is to wait. Okay. See here, this is the somatostatin. So the somatostatin is the byproduct that's released from the D cells. The D cells, once they secrete somatostatin, the somatostatin is gonna go and inhibit the proton pump or the hydrogen potassium ATPase. طيب? This hydrogen potassium ATPase's main job is to release hydrogen, is to secrete the hydrogen. So if we go and inhibit this channel right here via the somatostatins, this will inhibit the secretion of the hydrogen to the outside. And therefore, if there's no hydrogen, the chloride won't be able to bind with anything. Therefore, you don't have the HCl. This is the main concept. Okay, so the D cells just release the somatostatins. Good?
Yes, thank
Of course. Right. So, yeah, so that's the somatostatin. And again, anything, whenever there is excessive acidity, somatostatin is the thing that's being released from the D cells. To, yeah. And this is another job it does, and it inhibits the gastrin. Okay. طيب, now we finished the three phases. We're gonna briefly discuss the protective mechanisms the body normally has to protect its gastric mucosa. تمام? Because yeah, true, the stomach is used to its own acidic environment. However, how is it used to it? You know, we need to understand. There's four main things that the stomach has that helps in that. Number one is the mucus bicarbonate barrier. Mucus is basically gonna act as a physical barrier, right? And the bicarbonate is gonna basically neutralize the acid. I told you bicarbonate is basically a buffer. Okay, it's a substance that's released to alkaline anything. طيب? So the mucus is gonna act as a physical barrier, and then bicarbonate is also being released to try to neutralize the acid, and it helps maintain the pH of 7. Okay, now there are some diseases that do affect the mucus bicarbonate barrier itself. طيب, so يعني you can guess إنه if we damage this barrier, that means that the acidity can actually harm the muscles and the fibers of the stomach itself, and it can cause like damage, erosions, breakage, you know, just like destruction of a barrier basically. So this is why it is clinically relevant. Also, another mechanism that it has is the tight junctions. Tight junctions, you guys have taken it from before and like foundation and all throughout the blocks, but they're just junctions between cells, okay? And when you have these junctions very tight with each other, this prevents the acid from going and leaking in between the cells of the gastric epithelium. So, you know, it just like يعني it just maintains the acid in the stomach and doesn't allow the acid to seep in between the cells and damage them individually. Another mechanism is the fact that the stomach has a very excellent blood supply. As you will guys take in anatomy, there's an extensive blood supply to the stomach and the whole GI. And this is really helpful because that means if one of the cells of like or like if a portion of the cells go bad or they, you know, like they get damaged, we have very fast renewal. Within every 3 to 5 days, the gastric epithelial cells are being replaced, all of them, whether they're damaged, whether they're not, they're just shedding. And this is very, very good. Right. Lastly, we have the prostaglandins that we did talk about. Prostaglandins, other than the fact that they also inhibit the proton pump, they also stimulate the mucus and bicarbonate production, and this helps the mucosal integrity itself to maintain the barrier. And that's basically it. They can ask you about, like, you know, which of the following is a protective mechanism of the gastric mucosa. They can ask that. It's nothing in details. Right, so in short, for the phases, we have three phases: the cephalic, gastric, intestinal. The cephalic's main stimulus is sight, smell, taste, and thought about food, okay? And then what is going to be stimulated in this case? The vagus nerve. And then the vagus nerve is going to go and stimulate the GRP, tamam, to release the products and so on. And the whole purpose of this phase is to prepare the stomach for digestion. Okay, we don't have food in us yet. We're just preparing. And this is why the secretions are only limited to 30%. For the gastric one, as we said, it's the main thing because now you have food in your stomach, and this distended it, and this sent a stimulus and activated the vasovagal reflexes, right? Okay, and the vasovagal reflexes, as we said, what are they gonna do? They're gonna release acetylcholine, gastrin from G cells, as well as histamine from ECL cells. And all of this is gonna go and activate the parietal cell. Okay, remember, there's no direct communication between the vasovagal reflex with the parietal cell. It needs to happen via another leading hand, which is in this case gastrin and histamine. Gastrin and histamine. تمام. And this constitutes 60%. Lastly, you have the intestinal stimulus will be acidic chyme and nutrients in the duodenum, يعني food being present in the duodenum. And we said if it's too acidic, there's somatostatins, there's CCKs, there's secretin and GIP that are being released. And its main job is to regulate the chyme entry and neutralize the acid to make sure that it does not damage the intestinal wall. Because the main job of the intestine is not to digest, it's rather to absorb. And that's it. Do you have any questions before we go into diseases? About any of the phases or anything? I'm assuming all good. So now, for the clinical aspect, we're just gonna know a little bit, okay? So there's a very broad group of diseases known as peptic ulcer diseases, or PUD for short. Peptic ulcer diseases, from its name, you have ulcer in the stomach. Ulcer is basically just like you can think of it like you see in this image, it's like a gap. تمام. This is the normal mucosa and it's supposed to cover it straight. However, because of damage and erosion and breakage, it caused like a gap. طيب, and now acid is seeping into the gap and going into the blood and going inside. تمام, يعني it's going in this direction. Right? So there are multiple causes for PUD. As you said, it's a very broad group of diseases. So the first cause is excessive acid secretion. There are some diseases like ZES or Zongler-Elson syndrome. It's responsible for secreting so much acid. It's basically a tumor. It's a tumor in the stomach, I think, that causes overproduction of HCl. And this overproduction of HCl, it's gonna damage the normal protective mechanisms the body has for itself, and it's gonna cause an ulcer or peptic ulcer in specific. تمام? Another cause of peptic ulcer would be H. pylori infection, and this is about like 80%. 80% of cases are H. pylori infections. It's just an infection, تمام, that goes and damages the mucosal barrier or the protective mechanisms the body has for itself. And therefore, if we damage the mucosal barrier, obviously this makes it more susceptible for ulcers because acid is still being produced and, you know, that can damage it still. Okay, and this is the most common cause. Another thing is NSAIDs. NSAIDs are painkillers, so Ibuprofen, Solpadeine, Panadol, all of these. These go as a side effect they go and damage, command the mucus bicarbonate barrier. Okay? They go and damage that. Because basically, if you want to know, this is just like extra information, but NSAIDs, they go and inhibit prostaglandins, and prostaglandins' job is to stimulate the mucus bicarbonate barrier. So they indirectly damage the mucus bicarbonate barrier. Again, this is just for your information, but in general, yeah. Okay. Now, you don't have to know what exactly is ZDS. Like you just need to know, no, it's just causes overproduction of acids and NSAIDs in general damage the mucus bicarbonate barrier. However, for the H. pylori, it's quite important to know the mechanism in which the disease causes it. How can an infection cause an ulcer? So here you can see, the nature of the H. pylori is to produce urease, okay? Urease from the word urea, okay? Urease goes to convert the urea into NH3 or ammonia. تمام? So urea is normally occurring in the body. You will find urea عادي, okay? However, this urease enzyme, which is coming from H. pylori, is going to convert it into NH3. NH3, okay, it's an alkaline substance, right? So can you imagine with me the stomach that's supposed to be like very acidic? تمام? It's acidic for a reason, okay? It's like it's acidic to protect itself against bacteria, to digest food and everything. You know, it's a very like you can think of it as a very sterile area. تمام? So when I start to produce substances that alkaline it, تمام? يعني we're basically damaging the gastric epithelium and I'm creating a favorable environment for the H. pylori to grow. Because obviously it is an infection, so like they cannot withstand a very acidic environment. Like they can withstand it for like short amount of times. So how are they gonna cope with it and still live in the stomach? They start to alkalinize the stomach itself by themselves via secreting urease. Okay, so this is going to damage the gastric epithelium and to lead to inflammation and impaired barrier function. And this inflammation here, this inflammation will damage the protective barrier. It will reduce the HCl production. It will increase the hydrogen production. Like, it will just interfere with everything. You don't have to know everything in detail. However, it's just like a very destructive process of the barrier. Okay, due to NH3 being produced. تمام? And inflammation. Listen, whenever there's infection, there is inflammation. تمام? So this is the body's way of fighting an infection. So inflammation is صح, it is the body's way of fighting an infection, yet it is harmful. تمام? Obviously, it is still harmful for the body. And whenever you have, like, let's say, a cut or something, it starts to sting, it starts to swell, sometimes there's pus, all of these. This is a protective mechanism for the body, yet it hurts, yet it does have damages. So the same thing can be applied in here. طيب? Now, how can we manage H. pylori infections and how can we prevent peptic ulcers from being formed by them? We give them antibiotics. H. pylori is the bacterial infection, so we give them antibiotics. And we also could aid them with PPIs because now the stomach has ulcers in it. You can see there's openings in it. So imagine HCl being seeping out from it. So to try to reduce that, we give them proton pump inhibitors to try to reduce the HCl production. I know this is like affecting the overall digestive process of the stomach, yet we're really trying to balance the harm and good. Okay? Yeah, but if they're gonna ask you what enzyme the H. pylori is responsible for creating and what is NH3 ammonia. This is mainly it, I think. But yeah, do you have any questions so far about the clinical or anything? Okay. Inshallah, all good. Right, so now we go on to the do you guys want to break like 5 minutes to pray? Mm. Which part do you want me to repeat? If you still okay. Um, all right, we'll go on. It's okay. This part is a bit also kind of heavy. It discusses like the gastric motility. Like we finished the whole gastric juices and how they're produced and everything. Now we talk about the motility and how is the food exactly going from one place to another. Okay, تمام. هلا for the if you remember back in CVP what you guys took, you took something known as the pacemaker cells, right? And from the name itself, pacemakers are cells that basically produce a pace, produce a rhythm. And what is this rhythm called? It's called the basic electrical rhythm, or BER for short. Pacemaker cells, as you took in CVP, they were like SA node, AV node, the sinoatrial node, and so on, right? Now, you'd assume that pacemakers are just found in the heart. No, they're also found in other parts of the body, and they're found in the GI. However, for the GI, they're not called SA node or AV node. They're called the interstitial cells of Cajal or Cajal. It's like a Spanish word, I think. So, whatever, interstitial cells of Cajal, okay? So these cells, they are pacemaker cells, and they produce the basic electrical rhythm of the smooth muscles found in the GI. تمام؟ هلا pacemaker and BER are very broad terms. If you want to specify it for the GI, it's going to be interstitial cells of Cajal and slow waves. Slow wave is basically the BER. Okay? طيب. The GI system, as you know, is divided into multiple things. You have the stomach, you have the intestine, then you have the colon. صح? So these slow waves, they're gonna or these pacemaker cells, they're gonna be generating these slow waves, and these slow waves frequencies, they're gonna differ from each region of the GI to the other. In the um, in the stomach, we're going to be producing these slow waves every 3 to 5 minutes. Okay? In the small intestine, they're going to be every 12 to 20 minutes. So this is way higher. Okay? Yani way longer. And then for the colon, it's going to be 6 to 8. Okay? So the shortest is in the stomach, the longest is in the intestine. That makes sense because the intestine is really long. Okay? And the stomach is way shorter. Okay? You don't really, any the stomach is like circular. You don't really have to go between, how the colon, I mean, how the intestine is formed. Anyways, so this is it, okay? Now, these pacemaker cells, they need neuronal activation or neuronal supervision. Obviously, they're not cells that are working by themselves. They're contracting whenever they want. They're having action potentials whenever they want. Obviously not. They need stimulus. They need sometimes to contract, sometimes to relax. So these have from the higher centers of the brain and nerves and so on, they give them excitatory inputs and inhibitory inputs. Okay, this is basically a modulatory process. Okay, so excitatory inputs coming from the higher centers of the brain, they go to the pacemaker cell. تمام, in this case the interstitial cells of Cajal, and they're gonna increase and they're gonna tell it to go increase contraction. Yalla, I want you to contract right now. And whenever we don't want it to contract anymore, there are inhibitory inputs that are coming also from the higher centers, and they go up to this Cajal cells, and they tell it stop contracting. Okay. Now, what are the neurotransmitters that are going to be released with the excitatory inputs and the inhibitory inputs? For the excitatory one, you have the acetylcholine and the substance P, and for the inhibitory, you have the VIP and NO. And I want you to memorize these neurotransmitters like your name, because they're going to be mentioned over and over and over again in almost everything in your life, actually. But like specifically for GI. So the acetylcholine and substance P are released via the excitatory inputs to increase the contraction, and the inhibitory inputs will be VIP and NO, تمام, to reduce the contraction. Now, this is the pacemaker cell here, and they're present, like this is just a little bit about it. They're present in the longitudinal and circular muscles, and they are the ones that produce these slow waves via gap junctions. Okay? They have gap junctions between them. And this is what makes it unique. And the gap junctions are usually found in yes, you have a question?
Yeah, I don't understand how the pacemaker cells work.
Okay. All right. So pacemaker cell, tamam, it's a cell that basically produces the electrical rhythm of any muscle. Okay? Of any smooth muscle, my bad. Any smooth muscle. So skeletal muscles are muscles that like your biceps and triceps, you can control them. صح? But small muscles, you don't control them. So who's the one controlling it for you? The pacemaker cell. Pacemaker cells can be found all throughout the body, wherever the smooth muscles are. So specifically talking about GI, they're called the interstitial cells of Cajal. This is their name. Okay, and these interstitial cells of Cajal, they're going to produce the electricity to help the smooth muscle function. Okay, they're going to produce its electrical rhythm and give it the power to contract and relax. Okay, طيب, what are these electrical rhythms called? They're called the slow waves. They're called slow waves, okay? The way like I'd like to think about it and know why the naming is slow wave, and know if you want to compare the GI smooth muscles to other smooth muscles, GI is very slow. You know, you don't need rapid contraction. You know, actually the opposite. You know, and assassin, when you rest, you digest. It's a thing, you know. So this is why they're slow waves. They're named as the slow waves because they don't have very steep action potentials or very steep contractions, just like مثلا a bicep or like when you blink, you know, via your eyes. So yeah. Okay, so the interstitial cells of Cajal, they generate the slow waves, and these slow waves, they go and give the electricity or the electrical rhythm for the smooth muscles, either in the stomach, in the small intestine, or in the colon. All GI. تمام؟ هلا are these interstitial cells of Cajal working by themselves? Obviously not. They have upper control centers, and these upper control centers are in the brain. And what does the brain give the Cajal cell, or how does it modulate the Cajal cell? By giving it excitatory inputs and inhibitory inputs. Excitatory inputs is basically when the body is transmitting acetylcholine and substance P to this Cajal cell, and once the Cajal cell gets or receives the acetylcholine and substance P, it's going to contract. تمام? And if the higher brain center decided, and no, we don't want contraction, enough contraction, because you know, like every contraction has a relaxation. So whenever it decides that, it's gonna release VIP and NO to go travel all the way up to the Cajal cell, and the Cajal cell is gonna receive it, and then once it receives it, it reduces the contraction or it relaxes. Okay, does
So
that
the
make sense?
higher brain center controls it, right?
Yep, exactly.
Okay, thank you.
Of course. The higher brain centers, they're the ones that are releasing the acetylcholine, substance B, all these things. What happened? Oh yeah. The all these neurotransmitters are released from the higher brain centers. Okay. So moving on to dive deeper into the slow wave and everything. خلاص, we know in the slow waves they're produced via the pacemaker cell or the interstitial cells of Cajal. تمام. هلا these slow waves, they're always there. There's, or in other words, the muscles in the GI system are always contracting. But that doesn't mean they're contracting at a very high rate or like very يعني they're not always reaching a threshold. They have like a very, we call it baseline tension or tonic contraction. Your muscles are never really flaccid or in other words like completely like given up, you know? This only happens in like paralysis. Okay, بعيد الشر. بس yeah, in general, there's always tonic contractions, and always there are slow waves that are being produced. But when do we have the action potential, or when do we have the very like steep contraction? This is when the depolarization exceeds the threshold. Okay, when the depolarization exceeds the threshold, voltage gated calcium channels are going to open, and the calcium is going to go in, and you know the whole like shebang of the action potential happening and everything. Then this is just like any other action potential. تمام. Once depolarization exceeds the threshold, action potential is going to occur, the contraction, the very heavy contraction is going to happen, and then it goes down again due to repolarization. Very normal. Okay? And that's a slow wave. And that's what it does to a smooth muscle. تمام. هلا here you can see this is just something to point out that here you can see that there were multiple contractions تمام over a certain amount of time, so you can see the amplitude or the force of the muscle increased as well, obviously to maintain the same thing. طيب. And as we said, that the frequency or how many times will a slow wave contract depends on the part of the GI system. طيب, يعني in the stomach, do you need much contraction in the stomach? No, you don't. You don't. You're in the stomach, you're mainly digesting, and the stomach is already like circular, you know? You don't really need contractions in it. This is why the frequency of the slow waves is low in there. Okay, يعني slow waves obviously are there. I told you tonic contractions are always there. However, their frequency is low. If you want to compare it to the duodenum, it's really high in the duodenum because the duodenum is, or the small intestine is shaped in a way that like you need muscles to keep pushing the food down towards all the way to the colon. Even in the colon, it's يعني it's higher than the stomach in terms of frequencies. طيب, uh, yeah, that's basically it for the smooth muscles. طيب هلا there is a specific part that's very unique about the GI, which is its sphincters. طيب, the sphincters is basically, I want you to think of it of a circle of muscle. Okay, circle of the muscle. And this circle is found in multiple parts of the GI. It's found in the esophagus, it's found in the stomach, it's found in the colon, it's found in the anus, it's found in all these places. طيب, and its job is to always stay contracted. Its job is to tonically contract it. Tonic, I told you, tonic means no, it's baseline tension. It's always there. Okay? So sphincter's normal, يعني the normal resting state of a sphincter is contraction. Memorize this, okay? طيب, when is it gonna relax? It relaxes only from orders from the body or from the higher centers of the brain. Okay? And can you guess what neurotransmitters are released from the higher centers of the brain to relax the sphincter? VIP and NO, the same neurotransmitters that are released for the stomach, that are released for everything. They're the same. No? So they're released from the higher centers to tell the sphincter to relax. Now, why do we want our sphincter to relax? We want our sphincter to relax in order for the food or whatever substance to pass from one compartment to another. So let's give you an example of a sphincter. We have the lower esophageal sphincter. The lower esophageal sphincter is here. طيب, it's between the lower end of the esophagus and the stomach. طيب, so it's always contracted. طب let's say I'm eating food, I'm swallowing food. How will the food go from the esophagus to my stomach? It's gonna go via the يعني the sphincter is going to open, the lower esophageal sphincter is going to open, and the food is going to go in. Now, who instructed the LES or the lower esophageal sphincter to relax? The higher centers of the brain. So the higher centers of the brain, they release the inhibitory neurotransmitters, NO and VIP, and this NO and VIP relaxed the sphincter and the food was able to pass. Another example would be the upper esophageal sphincter. There's also the pyloric sphincter here. Right, this one connects the very end of the stomach with the very beginning of the intestine. No? So this one that we're actually going to touch upon later, this one is tonically contracted unless we want to pass food to the next compartment. طيب. Now, since we did talk about relaxation, very briefly, we're going to talk about different types of relaxation. تمام? This is kind of like how do you say this? This is kind of random info that was put in the lecture. It was actually a bunch of random infos, but like for the sake of completion, there's 3 types of relaxation, and I want you to think of it as in going from up to down, from the upper GI into the lower GI. So the first type of relaxation is the receptive relaxation, and this one is in the very up, in the mouth. Okay, this receptive relaxation happens only whenever there's swallowing. Okay, so the sphincter, the upper esophageal sphincter, the one that connects, like the one that goes from your pharynx down, it will only relax, تمام, whenever they're swallowing. How does this happen? Basically, swallowing puts pressure on the mechanoreceptors or pharyngeal mechanoreceptors, and once it senses this pressure, it's gonna open. Obviously, vagus nerve is involved and a bunch of nerves is involved, and you don't have to know all the details. You just need to know under receptive relaxation is found in the very upper GI, and it's triggered by swallowing. طيب طيب, for the adaptive relaxation, here we're going kind of down towards the stomach. So adaptive relaxation is from the word adaptive. It's due to stomach distension. When the stomach starts to distend, it starts to adapt, so it starts to relax. طيب, and this is via the vasovagal reflexes again. And stretch receptors. Stretch receptors, they're just receptors that get stretched, and when they get stretched, they just send a stimulus to the brain and know, oh, tada, we're being stretched. Again, we said feedback relaxation is triggered by duodenal nutrients. Whenever the duodenum starts to absorb the nutrients, it's gonna relax. طيب, and this is mediated via the local reflexes and hormones like the CCK. This was mentioned very, very vaguely to you guys now, because you're gonna talk about this later, specifically the CCK hormone, because it's very heavily, the intestines are very heavily affected by the CCK. So you're gonna know about this later. But for now, just memorize the bolded words basically, and receptive relaxation, swallowing, and so on. Now, let's say in a clinical relevant situation, يعني, an adaptive, let's say that we cut off the vagus nerve. تمام? If we cut off the vagus nerve, or for whatever reason the vagus nerve is not working due to مثلا head trauma or something, the adaptive relaxation, for example, is going to be affected, right? Because يعني, the stomach won't be able to distend. Okay, because the vasovagal reflex is not working, the brain is not registering the fact that there's food in you, so it wouldn't be able to distend the stomach. The يعني other than the fact that the HCl is not going to be produced and all these things يعني the fact that the stomach is not going to be able to distend, and this is going to create so much discomfort to the patient, and this is known as dysphagia. You don't have to know that, but it's basically just extreme discomfort, and I don't know, there's a bunch of surgeries they can do for that, but like yeah, this is just not important, but like yeah. Okay, now to a lighter subject, the gastric functions. A very obvious one is being a reservoir for food, right? It accommodates the food. It's a muscle. It can distend and relax whenever food is there or whatever. And it tries, and you don't really, and unless in extreme situations, you don't really feel that your stomach is being distended, right? You don't really feel that pressure rise in it, although there is a very, there is intragastric pressure increase. However, you don't feel it. Yeah. The second function of it is mixing or retropulsion. And I really want you to focus on this because this is high yield, okay? هلا, this is the stomach. طيب. And there's food coming from here. You swallow the food. The food is in your stomach. There's acid, there's gastrin, there's blah, 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 blah. Anyways, هلا, can the food come immediately out? Like, hey, just go in out? Obviously not. Because like يعني there wasn't enough time for it to break down. The particles are still big. Your burger still looks like it is, it barely broke down yet. So to solve this issue, the pyloric sphincter, this one here, is closed. It remains closed. Even if the food enters your stomach, it remains closed. Okay? It remains closed. So when the food comes in this direction, like the blue arrow over here, when the food comes in this direction, it's going to hit the closed sphincter and it's going to go back. And this is known as retropulsion. So this process of the food coming in and then going back and then coming in and coming back, it repeats for 3 times per minute. And this is known as mixing and grinding. The body here is trying to break down the particles as small as possible, as in 1 to 7 millimeters, so it can pass through the duodenum and not create any obstruction. Like also for the intestine to be able to absorb its nutrients. This cannot happen without mixing and grinding the food particles as much as possible. And also you want the gastric secretions to blend well with the food as well. تمام? So yeah, so until this is repeated 3 cycles per minute, okay, this is when the pylorus is gonna open, right? And via NO-VIP, and the food is gonna pass down to the intestine. Other than that, it's always closed, and via what neurotransmitters? Acetylcholine and substance B. It's the same neurotransmitters being repeated, by the way. To close the pyloric sphincter, acetylcholine and substance B. If you want to open it and خلاص the particles are mixed and fine enough, خلاص the VIP and NO are released. Yeah.
Why does the pyloric sphincter stay closed again?
Okay. So هلا, you ate food. Okay. Can the food, like when the moment it came in, can it come out like this very quickly?
No.
No, it needs to be digested, needs to be broken down, needs to be smaller in size and so on. This is why the pyloric sphincter is closed. Because if it's open, خلاص, the food is just going to pass right through from the very first go. But if it's closed, it will create like a wall for the food, and or like for the whatever fluids are found in the stomach, it's going to create a wall. And once the fluid hits this wall, it's going to go back. Just like, the pink arrow, it's going to go back. And this process is just like basically crushing the food smaller and smaller. It's not as
This is
retropulsion.
what normally happens, right?
Yeah, it's normal.
Okay.
Tamam. It's normal because otherwise it will let's say you ate like a very huge steak. طيب, a steak, if it just goes right out, it will create a huge obstruction in the intestine, and you can imagine how bad that can go. So alhamdulillah, this mixing or retropulsion exists. Okay? All right. Okay. So, this is another cute concept. هلا, when خلص the pyloric sphincter opened because VIP and NO were released, and the food is ready and everything is small, and yeah, the intestine is ready to take in the food. This is the process of the food leaving, or the chyme leaving the stomach to the duodenum, is known as gastric emptying. Literally from the name, gastric, the gastrum is being emptied. That's it. طيب. Although it's very simple, this is probably one of the most things they ask in this lecture. What are things that promote gastric emptying and what are things that inhibit it? So memorize these factors like your name, genuinely. I remember like back in my exam, I like we had like at least 3 questions on this. Anyways, they're very logical, يعني عادي. So things that can promote gastric emptying or can enhance the process of food leaving the stomach is number one, gastric distension. As we said, the stomach is being distended, and the intragastric pressure is increasing and increasing. You don't feel it, but it is increasing. So obviously, due to so much pressure, eventually it's gonna come out. Okay, and this is normal. Okay, this will promote gastric emptying. Also, gastrin release, obviously, because makes sense, the food is broken down at this point. If the gastrin is really high, that means HCl is being produced. That means that the food is being broken down. So that is good and that is normal. هلا inhibitors, on the other hand, are multiple ones. Number one, duodenal distension. And I want you to remember, and the promoting factor or positive factor is gastric distension, and inhibiting factor is duodenal distension. تمام؟ هلا, why is duodenal distension inhibitory? Because think about it. If you have distension or like food accumulating in your duodenum, do you want this food to go back to the stomach? No, like absolutely not. You know, this is just like this is like a chaos type of thing. Don't you want the no, like yani, this is why gastric emptying is inhibited whenever there's duodenal distension. Because like let's say there's like distension already in the duodenum and then you even push more food out of the stomach, okay? Or like let's say you put food back into the stomach, like no. This is just like no, okay? This is just going to create even more obstruction. So this is why it's an inhibitory thing. Number two is the high acidity. As we said for the 15th time, that the pH of acid can only be accommodated or handled by the stomach, not the other organs. So whenever there's very high acidity, let's say مثلا the mucous bicarbonate barrier is not working properly. Let's say the patient has H. pylori infection. Let's say there's overproduction of HCl. For whatever reason, there's very high acidity. This is going to inhibit gastric emptying. The stomach is going to force itself to hold whatever it has as much as possible because it is still very highly acidic and the duodenum and the intestine in general cannot stand it. تمام? Number three is hyperosmolarity. You don't have to go into details about this. It's just like, no, the food is like is hyperosmolar. That means that they're high in solutes and they're very not liquidy. They're really not liquidy. They're kind of solid. طيب? So whenever that happens, the gastric emptying decreases because you don't want that. Because it's kind of solid, if it goes into the duodenum while it's kind of solid or hyperosmolar, that means that it's just going to cause obstruction. That's one. Two, I don't want to go into details, like this is a kind of much, yani I don't want to confuse you guys, but like whenever something is hyperosmolar, water is gonna follow it. تمام, water from wherever, the blood from wherever it is, yani it's gonna follow it. And this is just gonna cause diarrhea for the patient as well as malabsorption. Because like right now the intestine is kind of distracted, you know? Yani I cannot absorb you and you're stuck in me, like what do I do? You know? Type of situation. And lastly, fats and protein breakdown products, because if you don't break them down properly, it's really hard for the intestine to absorb it, the nutrients. Lastly, you have the rate. هلا, if you want to compare a solid meal to a liquid meal, يعني drinking water to eating, I don't know, something. Sounds like something solid. Okay? Hello, liquid obviously doesn't need to be digested as heavily. يعني obviously a little part of it does, you know, like glucose and like مثلا if you drank a juice. However, liquid just goes immediately in and out. طيب, like just empty very quickly. However, solids, no, they have a lag phase. This lag phase or this LP stands for the grinding and mixing process, right? You know, you remember when I was talking about the pylorus being closed and then like, you know, retropulsion, all these things. Yeah, this is the lag phase for solid food. Liquids don't have that. So if you see on a table here, I mean, sorry, in a graph, you can see in the liquid meal just immediately goes out like this. Okay, it doesn't have lag phase. However, if you want to compare it to the solid meal, you can see it clearly does have a lag phase and it moves, sorry. It moves يعني the gastric emptying in it is slower because it's solid after all. And the semi-solid is like soup, for example. It is intermediate in between both. Okay, تمام. This graph is also pretty cute. It's very simple. You can, again, you're comparing here the liquid meal to the solid meal. You can always see in whatever part of the GI we're talking about, the liquid is obviously goes faster, way faster than the solid. Yeah.
Why do the protein breakdown products inhibit gastric emptying?
Okay, so fats and proteins in general, they're very hard to break down. Okay, if you want to compare it to other like carbs, for example, carbs are way easier. So you need your fats and proteins to be broken down very properly for the duodenum or for the intestine to absorb it, to absorb its nutrients. Otherwise, it's just gonna be stuck in there and just gonna come out in the stool. طيب? So this is why whenever there's like what the doctor means by here, I know the sentencing is like, or the wording is a bit weird. However, she means, and if the fat and protein is not broken down properly, this will inhibit the gastric emptying. You know, because we want the HCl to break it down really, or the pepsin to break it down really properly before it comes to the duodenum.
Okay.
Okay. And no lipids, think about it. Lipids, fats, how can you absorb fats, you know? Like you can't really absorb it into the blood like this. They're fat, they're globules, they stick to each other. So they need to be broken down very properly for it to be absorbed. Um, yeah, so that's about it for gastric emptying. They can bring you this graph and they can remove the labeling and they're gonna be like, okay, which one is a liquid meal? Or they can ask you in an MCQ and know which of the following meals has the highest lag phase, you know, sort of question. Okay. Last topic, again, a bit random, honestly, but we're gonna be talking about the vomiting reflex. Vomiting in general, it's a protective mechanism by our body. Whenever our body senses any irritants or toxins or something that is like not edible, let's say, or yeah, toxins in general, whenever it senses it's in the upper GI tract, all right, this is where the vomiting reflex is initiated. طيب? So this is exactly the steps that it goes through. Number one, here in the stomach, تمام, or in the upper GI, like even the esophagus, whenever there's distension or irritation to it, signals are going to be sent via the vagal nerves as well as the sympathetic nerves to the vomiting center. Vomiting center is a center that's found in the medulla or the medulla, and the medulla is found in the brain. So brain has many multiple like, you know, compartments. One of them is the medulla. The medulla is the control center. Think of it like this. And this medulla has the vomiting center inside of it. طيب? So whenever there's irritation or distension to the upper GI tract, it's gonna go via its nerves, vagus nerve, and it's gonna go stimulate the vomiting center. طيب, now the body knows and it wants to vomit. How can it prepare itself for the vomiting process? Number one, you'll notice and you will take a deep breath. Number two, you're gonna have elevation of the hyoid bone and larynx. Now, why the hyoid bone is like I don't know if you guys know what the hyoid bone, but it's like, you know, it's just a bone and like it gets elevated with the larynx to open the UES or the upper esophageal sphincter. طيب? Because we're trying to remove the, like we're literally doing the opposite of swallowing, you know? Sorry, of like no, that doesn't make sense. Anyways, we want to elevate, we want to open the sphincter, the esophageal sphincter, to let the food out. Okay, so elevation of the hyoid bone and the larynx, as well as lifting of the soft palate. I'm pretty sure you took this in anatomy, but the soft palate is like in the roof of your mouth, and it, like if you elevate it or if you lift it, you close over the nasopharynx. Because when you vomit, you don't want the vomit to go from your nose. Like you don't want that. So, and this is why like it gets the soft palate goes up. At the same time, we don't want the vomit to go to our trachea. This is why the glottis closes over the trachea, the airway passage. طيب, so you have elevation of hyoid bone and larynx, lifting of the soft palate for the nasopharynx or the posterior nares, as well as closing over of the glottis over the airway passage. Okay, now we prepared the passage for the vomit. Now, who's gonna actually create the power of the vomit? It's the diaphragm and the abdominal muscles. These muscles are gonna contract so hard to push the vomit outside, and at the same time, we were gonna have relaxation of the lower esophageal sphincter to allow the food to come out. تمام? So here, the upper esophageal sphincter is gonna relax, as well as the lower one is going to relax as well. تمام? And the only things that are going to contract are the diaphragm and the abdominal muscles. This is why actually your ribs kind of hurts. Your rib muscles kind of hurts after vomiting so hard because of the contractions. And then that's it. Then you have the food or like whatever irritant of you outside. But there's one more point to mention, and no, there's other causes for vomiting. Sometimes motion sickness can make you vomit. Sometimes taking certain drugs, like as a side effect, they can also make you vomit. صح? So these have a different pathway. They don't have the same like medulla vomiting center pathway. No, they don't. They have another zone called the chemoreceptor trigger zone. The chemoreceptor trigger zone is also found in the brain, and it's near the fourth ventricle. The fourth ventricle is not ventricles are not only found in the heart. There's also like four ventricles that are found in the brain. تمام. This chemoreceptor trigger zone is located near the fourth ventricle. طيب. And it's stimulated by drugs like morphine and digitalis derivatives and multiple other stuff. There's multiple other reasons. They're going to stimulate this CTZ to go and does the exact same thing of relaxing the sphincters and everything, and the same pathway, but different centers. Okay, same pathways, different centers. Now you don't have to know the names of the drugs. I'm pretty sure you don't have to, but for the sake of completion, morphine is just a very, very powerful analgesic. And for digitalis derivatives, I'm pretty sure they are cardiac medications. They're used for like arrhythmias, AFib, atrial fibrillation, I mean, and heart failure. Yeah, heart failure. But anyways, this is basically it for the vomiting reflex. Memorize the steps really well. I remember they asked us for the preparation and know what is elevated, what is closed, what is relaxed, what is not, stuff like that. So that's it. Do you have any questions? Because now we finished the lecture, we just have a couple of questions, like 4 questions. They're pretty easy. So, all good.
Yes.
Perfect. Okay. You can either type your answer in the chat or like open your mic. Right. So the first question, which of the following factors is most likely to slow down gastric emptying? Take your time. All right. We have one answer. Okay. Perfect. Right, so the answer is B, indeed. Because as we said, fatty food will slow down gastric emptying, صح? And like, for example, D, obviously not liquid meal does not even stretch out the stomach enough. Increased levels of gastrin is not related to gastric emptying. Increased frequency of prostatic waves, also not related to gastric emptying. If anything, that will promote it, if anything.
Isn't increased levels of gastrin a promoter?
We want to slow down the gastric
Yeah,
emptying.
okay.
Yeah, perfect. Good job. Okay, now the second question. During swallowing, which neurotransmitter is directly responsible for the relaxation of the LES? Mm-hmm. Anyone else? Perfect. Good job. It's the nitric oxide. Again, these are very, very, very high yield. Like this is probably going to come to you. Acetylcholine as substance B always, always contract, no matter what the smooth muscle is, no matter what phase are we talking about, cephalic, gastric, or intestinal, they always contract. Nitric oxide and what is the second neurotransmitter that also causes relaxation? Good job, VIP. VIP is the one that also causes relaxation. So yeah, good job. Now, third question. A 45-year-old woman presents with persistent nausea and episodes of vomiting. She recently started taking medication for a cardiac arrhythmia. Her cranial nerves are intact on neurological examination. Which of the following is most likely the explanation for her symptoms? Oh, okay. Any other answer? Okay. So the answer is indeed B. Simply because, okay, so she has persistent nausea and episodes of vomiting. So you need to immediately think of the vomiting center and if something is wrong in that issue and that reflex, something is wrong. Like, then I move on to the next medication for cardiac arrhythmia. So she's on medications. So they definitely mentioned that due to a reason. You know, معنات maybe we're thinking about maybe a side effect of a medication. No, it doesn't matter what this medication is, by the way. You don't have to know, no, it's for cardiac arrhythmia. Anyways, her cranial nerves are intact on neurological examination. So that means, and okay, and she's good. Like her cranial nerves are just like how do you explain this? Nerves and the very major nerves, okay? Like to your eye, to your like they just spread out. It doesn't matter. Anyways, neurological examination is perfect. So we can see and there's an overactivation of the chemoreceptor trigger zone. And the key word in here is medication. تمام? As we said, the CTZ is near the fourth ventricle and it's stimulated by drugs. تمام? And this stimulation is going to lead to the vomiting reflex without the need to have like a irritation or without the need for irritation or a vagal nerve dysfunction. Because if she had the vagal nerve dysfunction, there will be other symptoms like she'll be not able to digest food. She will have discomfort. She won't be يعني she wouldn't she you know she would assassin not be able to swallow in the first place. You know, it's a presentation known. I don't want to tell you the name of the presentation. It's kind of complex, advanced. But she wouldn't be able to swallow. She didn't present with any of this. She just presented with nausea and episodes of vomiting. This is why it's B. Make sense? If you want me to repeat the explanation, how do you don't mind? Yeah, I think we're good. Yeah, the last question. Um, okay. Which of the following best describes the unique feature of the pacemaker cells in the GI tract? Now, this is a bit like tricky. Well, not tricky, but boring. Read the option properly. The B. Okay. People who said B, are you still with B? Okay. Good job. Any other answer? I'm guessing no. Okay. So the reason why B was incorrect was because it is correct. I do agree with you, but they said always, and it doesn't always result. No, it doesn't always result in contraction. تمام. Slow waves are there, but as I told you, according to whether it's excitatory or inhibitory neurons, يعني whether acetylcholine or NO are being released, it will cause contraction and relaxation. تمام. طيب. This is why B is wrong. D, no. Gap, like these pacemaker cells, they're located wherever. You know, you don't just like just you don't just they're present throughout all the GI tract. A is wrong because they are. I know this wasn't mentioned very properly. Yeah, but like it's an intrinsic pacemaker. Okay, like it doesn't depend only on the external innervation from a vagus nerve. Okay, yeah, the vagus nerve modulates it, as in like it gives it inhibitory and excitatory neurons. Okay, but it is like like these pacemaker cells. They're within the body itself. They're intrinsic. They're the ones that set the rhythm. Like they're setting the rhythm by themselves. They don't need the vagus nerve to set the rhythm for them. You got it? Like they make their own intrinsic pathway, but the vagus nerve gives it the modulatory pathway of contracting and relaxing. You know what I mean? Did you get that? يعني in short, memorize this. Pacemaker cells, these interstitial like cells of Cajal, they generate their slow waves due to their own intrinsic pathway. Okay? Perfect. So be careful of like reading the choices. And this question probably won't come for you, but the other three are pretty high yield. Best, yalla, that's it. Thank you so much. Do you guys have any questions? I can repeat anything.
No, thank you.
Of course. This is the QR code. Please scan it to give me feedback. And if you guys have any questions, please like refer to my contact info in the beginning, and I'll be more than happy to help you with anything. And inshallah, you hope like you found this helpful. And yeah, thank you so much for attending.